This episode of Inside EMS podcast is sponsored by LogRx. Learn a better way to track your narcotics at logrx.com.
Well, it's that time of the week to go inside EMS. I am your host, Chris Cebollero, and with me always, and if you're watching on video, the man who combed his hair with a towel, Kelly Grayson. KG, what's going on with that too?
I did comb my hair with a towel. It get kind of froze like this from the pool, and I ran a comb through it, but the wind blowing and it froze at one point. So
They got hats. You
it's
can wear
time
a
to get the
hat.
hair cut again. That's what it is. Yeah. Oh, if you want to see me with a hat, I pull my hat off and it'll look even worse.
Well,
So
I'm just
this
assuming
is
you wore a
pool
hat.
hair.
Oh, it's not a hat hair.
No,
Yeah,
no.
'cause that's
This is the wind blown look.
yeah, the wind tunnel tested hairdo.
Yeah, that's right. That's right, man.
So the class,
You,
how's it
you,
going?
you, you're messing with my hair. Of course, both of yours are perfectly in place.
They are, man. And of course, I can wear my hat that you loved so much last week. I'll be loaning you money at the end of the show, so we'll figure that out. Guido will be coming to see if you don't
Yeah,
pay.
that's right. Yeah. Nice little podcast you got here. Be a shame if something was to happen to
Happen
it.
to it. That's right. How's the class going?
It's good, man. We covered heart blocks today and well, we covered heart blocks 2 or 3 days ago, but then they're still not quite a few still struggle, but
Hey, let's take that up
you
then,
know.
right? So I think that when we
Okay.
think about heart blocks, certainly as we started to make the shift in the 12 lead EKG way back when, we were in the
Yeah.
field before 12 lead EKG came in and we had to learn it as we went. But it seems that heart blocks, in 3 lead as well as 12 lead always caused a challenge, right? And as you get
Yeah.
more
Some
advanced
people
into
still
the
struggle to differentiate them. Yeah.
yeah, and even as you get advanced into the 12 leads, now you start to talk about bifascicular blocks, trifascicular blocks, so on and so forth. But really just the regular heart
Yeah.
blocks that we need to be able to try. And of course, type 1, 2 type 2s, and a type 3. How do you differentiate that? So Kelly Grayson, let me ask you this question. And you've been training
Yep.
EMTs and you've been training paramedics for a long time. What do you think is the biggest challenge with the understanding of heart blocks?
I think the biggest challenge seems to be differentiating the various heart blocks from one another and understanding the concept that some things are not really blocked. Some things are merely delayed, like a first degree block isn't to my mind an actual block. It's more like a delay since every impulse eventually makes it through the AV node. But when you mention bifascicular blocks and hemifascicular blocks, and when you're trying to get the concept of a bundle branch block down, that where one ventricle depolarizes in normal fashion in response to an atrial impulse, and the other one depolarizes sympathetically, and that's the wider part of the QRS, and that sort of thing. Smoke starts to come out of their ears a little bit, and we haven't even talked about the fact that the left bundle branch has multiple fascicles, and those can be blocked as well, further altering or altering the QRS width less so than a full bundle branch block would be.
Yeah,
But
man, you're just getting too deep, man.
one
You're
of
just
the
you're just confusing the heck out of me now. So I,
no, I'm not. No, I'm not. But each thing there is a season, So there's a time for this, and that time is in an accelerated class. That time is coming up Thursday, where we cover this in a little more detail. But one of the things that I'm trying to make them understand is that there's not a drug for every single thing. And sometimes the drugs that we give for one arrhythmia cause another arrhythmias. I'm prone to calling those drugs selective cardiotoxins. I'm not a real big fan of just willy-nilly administering emergency antiarrhythmics to people. I tell them the thing drugs like amiodarone and lidocaine and procainamide and the sort are kind of like chemotherapy. They kill the tumor just a little bit faster than they kill the patient. And the same is true of conduction problems. And one of the things that kind of blew my mind early on when I was a fairly new paramedic and I read Taigman's Advanced Cardiology in plain English and a couple of other texts that talked about how antiarrhythmics, particularly sodium channel blockers, actually work, and how and the way they work is they basically induce delayed conduction and make the ventricles refractory for longer, which is bad juju. If you're given to someone with underlying conduction disturbances, you can promote complete heart block, so getting them to understand that concept, that some of the drugs that we give are sometimes cause as many problems as they solve, is something that's slow in building. But they're starting to see my point in that I'm a big fan of Edison medicine. When it's really, really fast or when it's really, really slow and it really needs you to fix it right now, the best choice is usually electricity. So we've been kind of going through the heart blocks today and getting them well versed in that sort of thing and telling them what type of heart blocks might actually respond to a medication versus not. And
Well, let's go ahead and
they're getting there. They're getting there.
Let's take it back a couple steps then. So
Okay.
let's talk about the heart blocks that we're going to find in a regular EKG, right? So just a little bit of the anatomy as we think about this. The SA node, which sits at the top of the heart, is the primary pacemaker of the heart, which has an intrinsic rate of 60 to 100 beats per minute.
Yep.
So as that signal fires off from the SA node, it goes to the AV junction, and it's almost like the electric slide, right? And that's how I used to talk about it in class. So when you think about the SA node firing, that's going to cause the P wave to happen. And then as the signal moves to the AV junction, that's going to be the PR interval, right? So that's kind of the electric slide. It's a toll booth, and actually it has to stop to allow the atria to fire, to depolarize the atria, send the blood into the ventricles, because if it was automatic, the blood wouldn't be in the ventricles. So there has to be that pause. So you think of the AV junction.
You have to.
So you think of that AV junction almost as a toll booth. We got to stop. We don't have our money. We got to go into our pocket. We got to throw it into the bin. There's your pause. And then as it goes into the ventricles, it actually goes down two pathways. So it now depolarizes one side of the ventricles, depolarizes the other side of the ventricles. Okay. Now, anytime, and the intrinsic rate of the AV junction is 40 to 60 beats per minute, right? No, it's not right. It's 60 to 100, 40 to 60. Yeah. And then the ventricles,
AV junction is 40 to 60.
Right. Then the ventricles have their own intrinsic rate of 20 to 40 beats per minute. So if any time an electrical impulse fails, the backup is, okay, the SA node didn't fire. It's waiting. What the heck's going on? Where's that signal from the SA node? It's not coming. We better do something here, guys. This is our time. Go ahead and fire. Boom. Well, if that happens, what's going to be missing from the EKG? If the SA node doesn't fire, what happens, and what do we not see on an EKG?
You don't see a P wave, or you see a P wave that is inverted because it was depolarized from below, or absent altogether. But it's usually there, but it's often covered by the QRS complex. Or what really bakes their noodle is when they discover an inverted P wave in the ST segment, because the atria wound up getting depolarized after the ventricles did. And so they're starting to grasp that concept, but go ahead.
But let's touch on that really quick, because I think you bring up a good point. So when you have the AV junction fire in lieu of the SA node, it still sends the signal to the atria, right? Because something has to make the atria depolarize. So now you get, instead of the signal going down, which gives you the upward inflection, it's now going up, which gives you the inverted or the downward deflection, right? So this
travels
is where
toward the negative electrode, gives you a negative wave.
Exactly. So this is where now all the blocks are starting to happen. And as Kelly was talking about hemi blocks and bifascicular blocks and trifascicular blocks, and as that electrical signal now goes down the two ventricular pathways, what if one of those are blocked? How does that work out? And this is where this gets into this.
And now let's pause for a word from our sponsor.
Designed and founded by EMS professionals, LogRx provides real-time accountability of all your narcotics from cradle to grave. Reach out today for a demo and download the app on the iTunes and Google Play stores. And coming soon, LogRx will also track your medical supplies, equipment, PPE, and even vehicle checks. For more information, visit logrx.com. That's LOGRX.com.
So, Kelly, I want to ask you this. So, and hopefully I was able to clear it up a little bit. I think you got a little bit too deep, too fast. And sometimes I have to use my Kelly Grayson meter to all the smells have to. So I have a can of room deodorizer for all the smell that
I thought
Kelly
you
puts out.
like sprayed it on me like a cat that's playing with the house plants or whatever.
But I want to talk about, let's get into a little bit of this treatment now, right? Because there are different treatment pathways that you would want to take for a heart block. And of course, it's always treat the patient, don't treat your monitor.
Yeah.
But when you think about this, let's just think about some of this, if we think about maybe an SA node is blocked or an AV node has to fire, or if we think about treatment, what kind of treatments do we want to look for heart blocks?
Well, traditionally the treatment has always been for bradycardia caused by a heart block, and the treatment, traditionally has been atropine, and it still persists in the ACLS algorithms even now, although they're teaching 1 milligram of atropine for symptomatic bradycardia, whereas I remember the days when we gave 0.5 and went up if necessary. Getting them to understand the concept that not everything is going to respond to atropine and why is one of the big hurdles. And when you explain that parasympathetic innervation of the heart is not extensive throughout all of the myocardium, it's more concentrated in the supraventricular tissue than it is in ventricular, although it's a misnomer to think that the ventricles have no parasympathetic innervation. When atropine is not going to be effective. And this is something that I wasn't really appreciative of until, several years in my paramedic career, when I was introduced to the concept of an infranodal block, where you can have an AV block in a certain part of the conduction system, high up or low down. Low, when we talk about infranodal blocks, we're like deep in the AV nodal tissue, at or below the bundle of His, that those blocks do not tend to respond well to atropine. And to make the students understand that a third degree block with, say, a junctional escape pacemaker behaves a little differently than a third degree block with a ventricular pacemaker. And maybe that one with a junctional pacer may actually respond to atropine. The question is, should you get it to respond to atropine? And this is another one of those things. And I forget the name of the mechanism. Remember, and I'm sure you're familiar with it, but I can't ever remember the name. It's a cardioprotective mechanism that you often see that induces bradycardia in some MIs, and it's thought to be cardioprotective. Darn if I can remember the name of it, but it's a kind of a reflex. It slows down the heart rate, and if you got a patient who is having a high degree AV block because of a STEMI, or not say STEMI, because of an occlusive MI, which the current terminology is, and you want to raise their heart rate. Why do you want to raise their heart rate? Do you want to raise their heart rate to make you feel better because you're just scared to death at looking at a heart rate of 30 or 40? Or do you want to raise their heart rate because it's therapeutic for them? And that's the key. A lot of people will see a high degree heart block and go, oh my God, heart block, rate of 40. Oh, that needs to be paced, or that needs to be given atropine, but it's perfusing the patient well. And if it's perfusing the patient well, and it's getting blood to all their vital organs, particularly their brain, so they can talk to you, and even if the rate is kind of ugly and the patient is having an MI, is it really beneficial to the patient to raise their heart rate, or is that going to raise their myocardial workload and their oxygen demand? So hence explaining my preference for transcutaneous pacing when and if needed. And I taught them the best way to make an arrhythmia go away is to be prepared for the arrhythmia. You know, you've been doing this long enough that if you want to make sure that VTAC never appears, or that a block never appears, just have your pacing pads ready or your defib pads ready, and it'll never show up. It's only the only thing that works better at making arrhythmias disappear is holding your finger about that far from the print button on the monitor. It's guaranteed nothing cool happens then. But we had a few students today that just went straight to transcutaneous pacing, and I kind of like that they were obviously listening to me when I told them that high degree AV blocks probably are going to lend themselves toward pacing rather than atrophy. But I didn't want them to do it reflexively, you know, and they were still memorizing information and regurgitating it because they thought that's what their instructor wanted, rather than what was necessarily best for the patient, and applying some critical thinking to it. So I gave them some scenarios where the patient had a heart block but was relatively stable, even though the rate wasn't something pretty to look at. And what should you do for this guy? And thankfully, some of them actually were like, we're going to take a wait and see approach, and we're going to put the pacing pads on, and we're going to set the get the pacer ready, but we're not going to do it yet, and that sort of thing. And I was gratified to see that. Some of them still conceptually can't quite get the concept of the AV blocks now, although I gave them the AV block cheat sheet. You know, you've seen that one, the three questions you ask. Are there more P's and QRSs?
Right,
If the
right.
answer is no, then you're not looking at a high degree AV block. If the answer is yes, the next question is the PR interval fixed? If so, you're looking at a second degree type 2. And if the answer is no, then if the PR interval is variable, then the question left is the rhythm regular? Regular rhythms are by and large third degree blocks, and irregular rhythms, grouped beats, are second degree type 1. And they kind of got that. But the thing, Chris, that really seems to drive it home is my explanation of the marital spat. If you read the Nancy Caroline book back in the day, she talked about Sydney sinus and Virginia ventricle and AV node Abe and all this. Some of us favor to this, and I explain the concept or the pattern recognition of AV blocks as a marital spat, because one thing I've learned as an EMS educator over the years, if you want to make people remember something, you put it in terms of food or sex, and that'll of the tale of the marital spat, and how Sydney sinus and Virginia ventricle are happily married couple. And if you want to hear more about that, it's the R-rated version. You have to go to my blog. Sex, relationships, and the cardiac conduction system is the name of the post. If I explain it here,
where's my air freshener?
We'll get an R rating for sure.
I need my air freshener again. You just put, you know, so
but
I
it
think
works, and that's sort of, you know, conceptually they get it that way.
let me ask you this. I mean, so I think that was a good breakdown, but let me ask you this question. I mean, we talk about AV blocks, and then we talk about third degree blocks. I mean, so we know that, as we talked about earlier, we have the SA node that fires. We have the electric slide that pays the toll at the AV junction.
See, you've heard that analogy as well. Yeah.
So then what analogy?
That was from one of the Nancy Caroline emergency care in the streets. I think she was the one that originally put that in her books, the paying the toll and that sort of thing.
Oh, I made that up. I didn't read that anywhere. But anyway, if we think about a first degree,
buried in your subconscious.
If we think about a first degree heart block, right? So first degree heart block is going to be the normal PR interval should be 0.12 to 0.20 seconds.
Yeah.
Anything more than that is, and then you have a QRS segment, is a first degree heart block. So as long as it's consistent, so we have a P wave, we have 0.22, 0.22, 0.22. That's a first degree heart block. Normal QRS, normal QRS, normal QRS. Now, if we go to type 2 and a Winky block, we have a constant PR interval, But what happens is one of the QRS segments or multiple QRS segments will be missing. So what happens is SA node fires.
Oh,
sends it-
well, you got it twisted. You got it all twisted up in the game because you said constant PR interval, but with Wikibach, it's progressively lengthening. So, sucker, where's my bottle of air freshener?
Did I say the constant? All right, man. Well, I'm glad you're there. You're my safety net.
You just realized what you said.
So the PR interval gets longer, progressively longer. So the PR interval is 0.12, 0.16, 0.20, and then you have a missed QRS segment.
Drops. Yeah.
Yeah. And that could be multiple QRS segments. And then a type 2 is constant. And then you have a drop.
Yeah.
But Kelly, here's what I want to give an explanation about, because this is what really I think gives students and really maybe even the incumbent paramedics a little bit of challenge. How do you differentiate a type 3 complete heart block? Why does that cause so much? I mean, I think the big challenge is
AV dissociation.
Exactly. So how do you figure that out? How do you make that work out?
The wise old EKG Yoda that taught me my EKGs in paramedic school so many years ago. She's probably dead now, but her name was Inez Kernick, and Inez was a big fan of mapping out intervals with a piece of paper. She would lay a piece of paper over your EKG strip and mark what you think is a P wave, and go back left and mark the very next thing that you think is a P wave, and then see if those two hash marks are consistent across the strip. And she said, look, in a third degree heart block, it's usually a very bradycardic, very regular rhythm, and it is very regular in its own way, but the AV node or the atrial activity and the ventricular activity have nothing to do with one another. And when you say that the PR interval is variable in that, that's actually a little misleading, because there is no PR interval. There is no relationship. You have a regular P to P interval and you have a regular R to R interval, but they totally dissociate. They have nothing to do with one another.
Yeah, meaning there's no relationship. No relationship.
Because none of the impulses or the atria have made it through the AV node to the lower half of the heart. So something has to pick up the pacing function of the heart, and that will either be the cells of the AV junction, which will form a narrow QRS, or the cells of the Purkinje system, which is going to form a wide ventricular-looking QRS. And recognizing that sort of relationship is key in recognizing a complete heart block, as it's sometimes called. Those are ominous. That's a problem that needs to be dealt with right away, usually with transcutaneous pacing. Some of the old books said that giving atropine to third degree heart block may increase the rate or increase the degree of the block. I don't think that's so much true in that it may increase the sinus rate. So you may actually see what is a second degree type 2 block become with 2-to-1 conduction may become 3-to-1 conduction now. But it doesn't actually make the block slower. All you're doing is just speeding up the SA node, and whatever the escape pacemaker is just rocking right along at the same old rate. So it may look like, it's a higher conduction ratio than it was before, but it really hasn't done anything to objectively make things worse. And once again, I'm a big fan of pacing. If I think the patient's heart rate, it would be therapeutic for the patient's heart rate to be at 70. With the pacemaker, I can make it at 70. I don't have any guarantee that atropine is not going to get way back then. I don't even know if they talk about this, about block acceleration dissociation phenomenon, but which is a complete heart block, but higher up that it has an accelerated escape pacemaker, usually a junctional pacer. So, and some of those,
one of the things
you can speed them up and increases the workload.
Yeah, and I think that one of the things that we're talking about here is pacing, and I don't think that that's two things that we do very well in EMS. Paramedics don't pace, and paramedics don't cardiovert. And one of the things that you've got to be able to remember is that when those patients need both, do not hold that back. But because we're not doing it as often, we may not be as comfortable with that. But we're going to see people who are in third degree heart block, and we're going to have to pace them. We are going to see people in, an accelerated tachycardia. We're going to need, or SVT, we're going to need to cardiovert them. But Kelly, give your final thoughts here and then get us up on out of here for next week.
I'm gonna expand on what you just said before I let folks go. Is that when you have a hemodynamically unstable rate, fast or slow, when you have your patient is hemodynamically unstable because of their rate, that is treated with Edison medicine, and you don't need to hesitate to do that. If it is unstable tachycardia, synchronized cardioverter. If it is unstable bradycardia, transcutaneous pace it. But if it's not unstable and you're not doing it medicine, maybe the best is diesel fuel and a whole lot of vigilance, and maybe the antiarrhythmics that we continually we're prone to give may be less problematic than the electricity that we're scared of. But that's my thoughts. I'd like to hear your thoughts. Tell us what you think. What's your personal approach to treating tachyarrhythmias or bradyarrhythmias? Are you a fan of Edison medicine, or would you rather give them some adenosine or somatropine or some amiodarone, the Noah's Ark drug? We want to hear your thoughts and how you practice at the show at ems1.com. And for myself and co-host Chris Cebollero, thanks for tuning in to Inside EMS. We're going to catch you guys next week.